Thank you all so much for joining the 2019 Pre-Rulemaking Kickoff webinar. We have a host of speakers from CMS and some of our supporting contractors such as Mathematica and Battelle to support us during this meeting. First off, we're just going to go through a couple of housekeeping points. One, the meeting is moderated. All lines are going to be muted through the presentation, and we are going to be recording the meeting as well. You'll find soon the slides on the Pre-Rulemaking website, and within a couple of weeks we'll have a recording of the presentation with closed captioning through our YouTube as well. We will have questions during 2 points in the presentation. We'll pause around the 1:50 Eastern Time mark for about 5–10 minutes for questions, and then we'll have questions at the end of the presentation as well. Next slide. So we have a packed agenda for you. We're going to do a very brief meaningful measures overview. Then we're going to have a short presentation on interoperability. Then we're going to tie that into our rulemaking cycle and just give an overview of that. Then we're going to show you our CMS Measures Inventory tool, CMIT, as well as our new Environmental Scanning and Support tool, ESST, and do a short demo of both of those tools that should help you along in the process. We'll have a quick overview of the MAP, the Measure Applications Partnership. We'll review lessons learned and some updates, and then we'll have a live demonstration of Jira, and then close with a question and answer session. So before I get started with meaningful measures, just a super quick introduction. So my name is Kimberly Rawlings, and I am the core or the lead for the Measures Management System, and along with Helen Dollar-Maples, lead the pre-rulemaking cycle and tasks. So we are your CMS supports during this process. So hopefully everyone on the call has heard of Meaningful Measures and its initiative, but again, we just wanted to give a quick review since pre-rulemaking and the Meaningful Measures really go hand in hand. So in 2017, around I think it was like the November timeframe, CMS launched the Meaningful Measures Initiative, and our focus was to really improve outcomes for patients and reduce reporting burden and costs for clinicians and providers, and really have that relationship as well as those two parties really be center at everything that we do. And so we feel that with Meaningful Measures, it's going to allow us to really focus on quality measurement and improvement and better align it so that we're really only doing those tasks that are most meaningful to our patients. And so we recognized prior to having Meaningful Measures that there were too many measures, that there was a lot of administrative reporting burden, and that there wasn't really a lot of focus within our measure sets. You know, we heard time and time again that measures would go through the pre-rulemaking cycle, get to the MAP, and people had a really difficult time kind of connecting the measures that they were seeing in the pre-rulemaking cycle and in the MAP and on the MUC list. They had trouble connecting that with the previous CMS quality strategy. And so Meaningful Measures really came to help make a connection between the quality work that we're doing in the big picture and the measures that we have in our programs as well. And so here we have our 4 CMS strategic goals: empower patients and doctors to make decisions about their care. Very clear how Meaningful Measures really ties into that. Again, putting that relationship at the center of this initiative. Ushering in a new era of state flexibility and local leadership, support innovative approaches to improve quality, accessibility, and affordability. There we have both innovation and quality, two things very key to quality measurement at CMS, and then also improving the CMS customer experience. And this, I think, ties into meaningful measures as well, because meaningful measures is helping us better communicate. And, obviously communication will really help our customers, our patients, our providers, et cetera, have a better experience as we're communicating better with them. So a lot of times when people think of meaningful measures, they think about the circle and the framework, and we'll definitely get to that. But at a higher level, meaningful measures has several objectives. They're there to really make sure that we are developing the best measures possible and the highest quality measures possible, and making sure that everyone's going in the same direction and that all of our efforts are focused on the same types of measures. And so these meaningful measure objectives really get us to what characteristics are we looking at, what characteristics should those measures have. And so I'm not going to go over each one in a whole bunch of detail, but, I've mentioned burden several times. It's important that we're minimizing the level of burden for providers through our measures. We do have some program statutes that need to be fulfilled. Things like aligning our measures across programs and with other payers, like we do with the Clinical Quality Measure Collaborative. And then, of course, making sure that our measures are addressing high-impact areas as well. And then there's some other things like making sure outcome-based where possible, et cetera. So with this framework, our two goals are to really make sure that we are providing high-quality health care for patients and that we're having meaningful outcomes for patients. And we, of course, did not do this work in a silo or alone. We drew on lots of work from others. So this was actually launched at LAN, so they were definitely a part of that. There were several tie-ins with the National Quality Forum, or NQF, and then NAM was also a critical part of this. And then we also have perspectives from several others, both internal to the government as well as externally. And just as we didn't develop this alone, we can't do this alone. And so we wanted to articulate several kind of key levers that help us achieve this work more globally, and things that not only we can align with throughout the agency, but also other things that we think that non-CMS developers can really support. So, levers like making sure that our patients are engaged and providers are engaged throughout the measure development process, and making sure that we're getting the voices and perspectives of frontline healthcare professionals who are the ones actually doing and implementing and giving us that data for our quality measures. Maria Durham's going to talk in a few minutes about interoperability, and strengthening interoperability is crucial to reducing burden for our clinicians. Optimize public reporting, making sure that the data is accessible, that it's actionable, and making sure that patients and caregivers have access to that data. And there are lots of exciting things going on throughout CMS to make sure that patients and caregivers have increasingly more data. Also aligning our measure portfolios. Again, making sure that we have strategies for our measure selection across the entire agency, making sure that we're focused on patient-centered outcome and longitudinal measures. And then also aligning quality measures and value-based purchasing. So making sure that our policies and processes for quality reporting and value-based programs are aligned with everything, and making sure that, again, everyone's moving in the same direction and we have a unified voice, not just in one program, but across our programs. But having said that, we always need to balance that singular voice with making sure that we have some flexibility to test different innovative models to make sure that we're getting the best outcomes possible. And so this is a framework that I'm sure everyone is very familiar with and seeing. So at the center, as I've already described a couple slides ago, we have our 4 CMS strategic goals, along with a pictorial depiction of the provider and patient. Again, really emphasizing that relationship is at the core of this framework and really at the core of what we're trying to improve here. Around that circle, we have 6 cross-cutting criteria: eliminate disparities, track to measurable outcomes and impact, safeguard public health, achieve cost savings, improve access for rural communities, and reduce burden. And by cross-cutting criteria, we really mean is that these are criteria that all measures should touch upon when they're implemented into our programs. And this is kind of articulates of what we're really looking for in our measures. In the bold list, or bolded in the list, we have our 6 healthcare priorities. So promote effective communication and coordination, promote effective prevention and treatment of chronic disease, work with communities to promote best practices of healthy living, make care affordable, make care safer by reducing harm caused in the delivery of care, and strengthen person and family engagement as partners in their care. And underneath of those, we have our 19 actual meaningful measure areas. And again, what these meaningful measure areas are supposed to do is try and link between this make a link between this very broad quality priority, such as make care affordable, and the actual measure. So it gives you kind of, you can think of it as a couple of categories underneath of make care affordable that are a bit more specific to again, help make that connection. And to just do a quick walkthrough of one, so you kind of see a little bit more how it works. Again, we have the healthcare priority of promote effective prevention and treatment of chronic disease, and then we have 5 meaningful measure areas underneath of that. I won't read through each one, but we'll just take prevention and treatment of opioid and substance use disorders as one example. So that's our meaningful measure area. And then here are 2 examples. There are many more, but here are just 2 examples of measures that we've assigned to the prevention and treatment of opioid and substance use disorders meaningful measure area. So we have alcohol use screening, which is used in our inpatient psychiatric facility quality reporting program, and then use of opioids at high doses, which is used in our Medicaid and CHIP program. And I think that Vince from Battelle is going to touch on this much later in the presentation, but one, it's really important that we discuss and kind of do a quick recap and review of meaningful measures. One, because this is what guides our work, not only in us trying to articulate to you the areas that we're most interested in, but also, working to categorize our measures by these areas so we can see more clearly where the gaps are and where we can articulate, here's where, we see a gap in management of chronic conditions. We would like more measures in this area. So again, coming back to that communication aspect and how this is going to help, how this helps us better focus and articulate our needs and priorities to you. And, obviously with the pre-rulemaking and creation of the MUC list, this helps us articulate those priorities for us. And then when you enter your measures into Jira, you'll be asked to assign a meaningful measure area to the measure that you are submitting into Jira. And so with that kind of overview of meaningful measures, I'm going to turn it over to Maria Durham, who's going to talk to us a little bit about interoperability. And if you could give us the next slide, Martin.
Thank you, Kim. I'm Maria Durham, and I'm going to briefly take this conversation up a notch to the 30,000-foot level to talk a little bit about CMS's strategic priorities for 2019. And this is something that Administrator Verma articulated at the Quality Conference. She really talked about focusing on results, empowering patients, unleashing innovation, and of course, talked about transparency and innovative payment mechanisms to really help us towards achieving these 3 goals. And they all kind of have one thing in common, and they all rely on interoperability. And when we say that, we mean the technology and the ability to share data seamlessly. And this is something that is so important in healthcare. So CMS has been working on interoperability for a while. It really started with the EHR incentive program, and now it has kind of transformed into promoting interoperability. But it's really hard, and we kind of ask ourselves, like, why is healthcare such a siloed mystery? You know, first and foremost, I think it's because people don't want to need healthcare. And at some point, we do need it, and there are a lot of players when we do need it, and it's complicated. Insurance coverage for those who have it may be provided by Medicare, either Parts A, B, C, D, 50 different state Medicaid programs, Medi-Cal if you're in California, Medicare Advantage, Medigap plans, CHIP, the Veterans Administration, the military, and hundreds and thousands, and literally hundreds of thousands of private employer-provided plans, as well as the individual insurance market. So each one of these plans has its own web of providers, suppliers, facilities, and other partners that all kind of overlap and intersect and all participate in the health of Americans. So it's really important to advance interoperability in order to advance our goals, because without effective open data sharing, providers, you know, can't keep patients healthy in the way that they all want to. We also need data to track patient progress and to understand quality. Insurance companies, such as CMS, really can't tie payment to outcomes, and that's the very underpinning of all of our CMS quality programs. Something like that should be simple, tracking down records. And really, you know, I'm going to tell you a short personal story, and it really demonstrates how our system is maybe not as patient-centered as it could be. I was running about 7 months ago, and like all old ladies that go running, I tripped and broke my elbow. And the interoperability component that I experienced was that I had the opportunity to pick up a CD with my broken elbow from one office and drive it to the other office so that the specialist would have the critical information he needed to give me a proper plan of care. You know, had I not been able to do that, the lack of interoperability could have led to disconnected care, worse health outcomes, and higher costs. I'm fairly certain he would have just retaken the x-rays all over again. And unfortunately for many patients, that's a reality. So we're working to change that. You know, the reality for patients should be that they're able to take ownership of their own health data. And I don't mean by driving from one provider to another as I did, but there is an interoperable health data exchange, and that happens for them automatically. You know, we really want to make sure that we enable a system where providers can provide the best care of their patients because they have accurate, timely information readily available to help, in conjunction with a patient, make informed decisions. An interoperable healthcare data exchange enables coordinated care, improved health outcomes, and reduced costs. With greater technical efficiency, we won't need to repeat expensive tests, and we'll decrease the risk of adverse drug interactions, and those are just 2 examples. Having an interoperable healthcare data exchange is a way of putting patients first, and that's what it really looks like. So how might we get there, and what in the world does this have to do with all of our quality measures? Well, you know, I'm talking at the pre-rulemaking kickoff meeting, and you know, we have been doing meaningful measures, as Kim talked about, for a couple of years now. And in the beginning, CMS was really looking at our measure sets and reducing measures that weren't meaningful. But at this point, we've done that, and we've identified gaps, and we are developing some measures, but we're also changing the way that measures are reported and the way the data is transported. We're creating policies that drive to a system where doctors and their patients are incentivized to make sound decisions based on patients' information in a safe and secure environment, and that's what the interoperability is all about. Interoperability will support our quality work by helping to ensure that the low burden of data collection and exchange and make sure quality measure data feeds into the planning and implementation of quality improvement activities. EHR-based ECQMs are considered a very high priority for CMS and for most of our programs, and additionally, we're considering FHIR standards to help make them even better. Although EHRs are only a component of interoperability, they're essential to the overall solution. Our ability to standardize on structure, semantics, on common meanings of medical terms is quintessential to the success of data sharing. By proposing FHIR standards, we are promoting scalable data sharing, not just an individual patient record from hospital to hospital, but a model that supports the flow of information across the entire healthcare system, and that's what's really needed. So interoperability is baked into meaningful measures at a variety of levels. In addition to the meaningful measures area titled Transfer of Health Information and Interoperability, we have cross-cutting criteria to track to measurable outcomes and impact, achieve cost savings, reduce burden, and we also have quality priorities like promote effective communication and coordination of care, and that was the subject of a very big grand rounds today, and make care affordable. Advancing interoperability not only supports, but it advances these areas, and interoperability is part of that solution. You know, I think we have a lot of components that give us the road to great quality care. That's what we really want, but we need to make those roads connect, and I think that's really where interoperability comes into play. So with that, I'm going to turn it back to Kim, who's going to talk a little bit more about pre-rulemaking.
So pre-rulemaking is statutorily mandated by Section 3014 in ACA, specifically, and Section 1890 and 1891 of the Social Security Act. Basically, there are three main steps to the pre-rulemaking cycle. We have the publication of the measures under consideration list, which must be completed by December 1st. Then, typically in early December, the National Quality Forum will convene the multi-stakeholder groups, also known as the MAP, the Measure Applications Partnership, and Helen Dollar-Maples will be giving a quick overview of those a little later. And then the third step is that the MAP provides recommendations and feedback to the Secretary every year by the following February 1st and gives recommendations on the MUC list, from the MUC list, and which measures they feel should go forward. For the MUC list, there are a couple of things to keep in mind. One, the MUC list is only for new measures. So measures that are currently in use and currently in the programs do not need to go on the MUC list again. The only exception there is if there are substantial changes to that measure, then that measure, like a change in population or a change in setting, et cetera, then that measure would need to go through the MUC list again. Submissions are accepted if the measure was submitted in the prior, so if the measure was submitted the prior year, but it was not accepted by any CMS programs, then it would need to go on the MUC list again. And then, again, kind of to the first point, that we know that measure specifications change over time as you're updating and evaluating your measure. And so if there are significant changes, you know, you may want to submit them on the MUC list again. Next slide. So not every single program goes through the pre-rulemaking cycle. It's only these 18 listed here, and they're all Medicare quality programs. So with the pre-rulemaking cycle, of course there are a lot of things that we consider when we're choosing measures to go on the MUC list, but here are a couple that we kind of think through. One is, you know, does the submission align with the quality priorities? So going back to meaningful measures and those 6 priorities like make care safer, make care more affordable, et cetera. Is the candidate measure fulfilling a meaningful measure area gap in this program? Like I said, we use meaningful measures both to evaluate measures in our programs, but we also use them to categorize measures and have us look forward and note which gaps, you know, where we need new measures. And we'll be talking more about that on April 25th, so next Thursday, where we have an entire session where each of the programs will walk through the needs and priorities of their particular program. So we think about gaps and filling those. We also look at the program as a whole and try and make sure that we are identifying any possible duplication of measures, not only from the public sector of us, but also the private sector, and just making sure that we're getting the best measure possible and trying our very best to not have duplication. We want to make sure that the measure is evidence-based, fully developed and tested. And this is a really key point. I think in past years especially, you know, measures that were not fully tested were not allowed to be on the MUC list. And I think that that's still kind of where a majority of measures, or one of the reasons why measures are not accepted on the MUC list. It's probably our #1 reason, is that they're not fully developed and tested. And when we're thinking about them being evidence-based and fully tested, et cetera, we also want to make sure that we're paying attention to burden and making sure that they are least burdensome as possible. And then lastly, we consider whether the measure has been endorsed by NQF. And, you know, I realize that that can definitely be a process, and sometimes measures go on the MUC list before they start the endorsement process, and that's when we think about, is the measure, quote-unquote, endorsement ready? Has it been fully developed? Is it tested? You know, would it be ready to submit to endorsement? So, again, not a 100% complete list, but just a few of the things that we pay attention to. Next. And of course, development and everything of a measure takes time. But once we have a measure that's, you know, completely developed, has been tested, et cetera, then it starts the measure implementation timeline. And, you know, that can be a long process. So here, you know, we have, first you start with a fully tested and developed measure. You submit it to the MUC list through Jira, which is what's happening right now, and that closes very shortly in early June. Then we will take all of the measure submissions, we will review them, make recommendations, and put that list through clearance, and then publish the MUC list annually, again by December 1st. Then the MAP weighs in, and then that work group makes recommendations, and then and those recommendations are made by February, and then CMS and HHS will take those recommendations of the measures in the MUC list and put some of those measures in the proposed rule for that program. Then the final rule is issued, and then finally, kind of as a last step in the implementation timeline, the measures are adopted in the field. And so for this year, in 2019, we have a couple of dates, and I will note that these have shifted a little bit. So Jira opened, people can already go in and start submitting measures. So that opened February 26th. As I mentioned, Jira is closing for all measures June 3rd. That's a Monday. By mid-July, we will have CMS will have a draft MUC list prepared. We will review that a couple weeks later during our federal-only stakeholder meeting, and they'll kind of have a preview to the MUC list. And then the clearance process begins. And this is a little bit earlier this year, again, because we're kind of moving up the timeline to give our rule writers a bit more time to digest the recommendations from the MAP and allow people more time to have public comments on the NPRMs and the rules. This diagram is really meant to depict, as you can kind of see from the timeline, that we're constantly somewhere in the process. You know, the recommendations to the to HHS and the HHS secretary are made by the MAP February 1st, and in February we're already putting together Jira and opening Jira. So it really is this kind of overlapping process. So we're constantly in at least 2 MUC cycles in really any part of the year. As I alluded to earlier, there's been a trend kind of in the decreasing number of measures on the MUC list. In 2011, we had a record number, or sorry, not a record number, that was 2012. We had 366 measures that were on the MUC list, quite a lot. And as you can see from this table, over the years, it's gotten smaller to, our smallest in 2017 with 32 measures, and in 2018 with 39 measures. And there are a couple of things that are playing in here. I think part of this is definitely, hopefully, our communicating better of our needs and priorities, not only with the areas that the measures are in, like whether it's a substance use measure or whether it's preventive care measure, but also, our communication and the types of measures. So really, again, focusing on outcome measures, making sure that the measures are patient-centered, patient-reported if possible, et cetera. So I think, the decrease in the number of measures on the MUC list really speaks to our communication and focus around that and what we are looking for. And, if you're interested, all of the previous MUC lists can be found on our pre-rulemaking website from all past years. And so we do have a couple of lessons that we have learned over the years. Again, like I said, relatively fewer measures were accepted on the MUC list because of, continuing and evolving criteria. A real emphasis on testing data and making sure that the measure is fully tested. And we're actually going to have a short presentation on ECM Readiness that will speak a lot around testing later in the presentation. In 2018, we did a separation of MIPS cost and quality measures. And then measure owners can gather measure information in advance offline. We've heard this has been very helpful for folks. And then what we're looking for in the future, and what I alluded to a little bit earlier, is really trying to allow the MAP work group sufficient time for review, allowing for, more longer public comment periods, et cetera. And so in the future years, we're looking to continually bump up that timeline a little bit. So, last year, with the exception of the MIPS quality measure, all the other measures, Jira closed on June 15th, I think it was. Around that date this year, all of the measures across the board are closing June 3rd. And next year, we're looking at possibly closing around mid-May. So again, moving up the entire timeline. So just a quick plug for some of, previous slide, 1 minute, there you go, thank you. So just a quick plug for the other webinars in the series so you can learn more about pre-rulemaking. We have both of our open forum discussions, one this Thursday, a second one next Tuesday, same time. And the open forum is really a live demonstration, a longer live demonstration and instruction of Jira where you can ask questions about data fields and how it works and what's the process, et cetera. They're pretty much the same presentation, so you only need to come to one. And then I mentioned this earlier, but we have the Needs and Priorities webinar next Thursday, the 25th, from 1 to 3 p.m., and that's where each program is going to walk through. Each program is going to walk through the needs and priorities for their program by meaningful measure area. And then if you have any, there are lots of resources on our pre-rulemaking website as well. So please, if you haven't already, feel free to check that out. And now I'll turn it over to Susan, who's going to give us an overview of the MIPS Peer Journal.
Thank you, Kim. This is Susan Arday, and I'd like to briefly talk about the MIPS peer-reviewed journal article requirement. Next slide, please. CMS is required to submit the proposed MIPS quality measure and the method for developing that measure for publication in an applicable specialty appropriate peer-reviewed journal in order to add a new measure into MIPS. As you can see, this is under Section 1848Q2D14 of the Act, is added in Section 101C1 of the Medicare Access and CHIP Reauthorization Act, MACRA. Why is this important? Because measure owners submitting measures into Jira have to complete the required information by the call for measures deadline, which this year is June the 3rd. Some of the information requested in the peer-reviewed journal article requirement template may be listed in the specific fields in the Jira tool. However, to ensure that CMS has all the necessary information from a measure owner steward that's submitting, and to avoid delays in the evaluation of your MIPS quality measures that you're proposing, please fully complete the form as an attached Word document and then put it into Jira. The information in Jira must be consistent with the information on your form. And let me see here. There's a number of benefits to this. One is that you're providing clinicians with the information on clinical quality measures, including specialties who don't necessarily have access to or involvement with the MUC list and the MAP processes. Also, eligible clinicians will be more aware of the types of quality measures that can be reported to CMS under its quality programs. Next slide. So each measure submission must be committed and accompanied by a completed peer-reviewed journal article form, as I mentioned earlier. The completed peer-reviewed journal article form should be submitted in Jira as an attachment to the measure submission. The required information includes comprehensive reliability and validity testing information. That's essential. You must have that in your form. It is recommended that you copy or paste any duplicative information present in the Jira submission and put that in your peer review template form to ensure, as I mentioned previously, consistency. The blank template and some completed examples for both non-electronic clinical quality measures and also electronic clinical quality measures are available on the CMS Pre-Rulemaking website and on the QPP Resources Library in the Call for Measures and Activities zip file. And this is the standardized process for collecting this required information through this MIPS peer-reviewed journal article form. The template is subject to change each year, so please make sure for a given year you are using the most current and accurate template. If you want to access the latest version of the MIPS peer-reviewed template, in examples, here we've got the URLs that you can use. And I mentioned this before, to go to the QPP Resource Library and go to the Quality Initiatives Assessment Quality Measures Pre-Rulemaking website. And now I'd like to hand this over to Christine Holland, who's going to talk about ECQM readiness.
Thanks, Susan. So electronic clinical quality measures, or ECQMs, submitted to the call for measures have some additional considerations and requested information so CMS can make sure that the submitted measures are ready for implementation in MIPS. We refer to this as our ECQM Readiness Check. Next slide. The first part of the ECQM Readiness Check relates to testing the characteristics of the ECQM. So feasibility is an especially important consideration for ECQMs in a national program. CMS requests that each ECQM submission to the call for measures include a completed NQF feasibility scorecard or other quantitative evidence indicating the measure can be reported by the intended reporting entities. This NQF feasibility scorecard is publicly available on the NQF website. Additionally, as mentioned earlier and similar to other types of measures, validity and reliability testing of the measure using data from EHRs is required. For ECQMs, validity is typically established through a correlation of data element or measure score with a gold standard. So for example, an approach for assessing data element validity would involve calculating the kappa agreement between data elements electronically extracted from the EHR and those same data elements manually abstracted as the gold standard from the EHR. Examples of other suitable statistical tests for validity and reliability are provided on the slide. CMS requests information about the data used for testing, such as the number of providers and the patient panel demographics, to further understand the approach used and to put the results provided into context. The second part of the ECQM readiness check relates to the specification readiness of the ECQM for implementation in a national program. So ECQMs must use the measure authoring tool, or the MAT, to specify the measure. The call for measures requests the MAT number and MAT package for all submitted ECQMs. The value sets for ECQMs must be created in the National Library of Medicine's Value Set Authority Center, or VSAC. The call for measures requests attestation that value sets are published and publicly viewable in the VSAC. The ECQM logic must be tested using a Bonnie tool, which uses test cases to verify the measure's logic is working as intended. For inclusion in MIPS, an ECQM must have test cases that cover all branches of the logic with 100% pass rate in Bonnie. The call for measures requests the Bonnie test cases for the measure showing 100% logic coverage. Slide 35, the next slide, lists resources to support the development and submission of ECQMs ready for implementation in MIPS, including the Value Set Authority Center, Bonnie, the blueprint, and ECQM testing requirements related to feasibility. I believe at this point we're going to pause for a question and answer session.
Yes, thank you. Please, if you have any questions, please feel free to submit them via the chat box or the Q&A feature.
Kim, this is Vince Brown from Battelle. We have had some questions come in online during the earlier presentations. One was, can any of the speakers define what does fully tested mean for a measure? And maybe Christine just covered that, I don't know, but.
So anybody else feel free to weigh in here, but this is Maria Durham and I'll take a stab at that. I think when we're looking to put measures on the MUC list, you know, we want measures that are NQF endorsement ready, meaning that they have had reliability, validity testing, and that they, if they haven't already been submitted and NQF endorsed, that they have been sufficiently tested and are scalable to a national level, and there's some evidence, you know, that that testing has been done.
This is Susan Arday. For the MIPS quality measures, we look for testing at the clinician level. We really need you to provide testing results include the N value, in other words, the number, how many practices, how many individual clinicians did you use. If they're ECQMs, as Christine mentioned, we need the Bonnie test case results. We need your correlation coefficients and any other pertinent information or values that should be considered. We need your reliability testing results, your validity testing results, including your clinician sites, how often you had exclusions, what frequency of your exclusions were there, and things like what was the minimum sample sizes you used for reliability results. Is the measure risk adjusted? If so, how is it risk adjusted? And don't just say, yeah, it's risk adjusted. Actually kind of explain to us how you came to why it needed to be risk adjusted, what the adjusters are, and why those are important, what's supported in the literature for that. And then also, what kind of benchmarking information do you have available so that we can get a feel for what should be the target, not just the ideal, but where are we hitting at right now on this measure to see if there's a significant difference between, if a measure you've designed is already pretty much everybody's performing perfectly at it, there's really no need for it to be incorporated into one of our programs. So.
Yeah, and this is Kim. You know, if you're unfamiliar with the process of testing and the various components, you know, I definitely encourage you to, you know, consult the Measures Management System Blueprint. You know, you can specifically start with Chapter 22 on measure testing, you know, and they'll kind of talk, and it kind of walks you through, you know, what is, at a high level, you know, what's alpha and beta testing, you know, how do you implement a testing plan and, you know, analyze those results, you know, et cetera. So definitely use the blueprint as a resource if you're unsure what testing measure, what testing a measure looks like.
Okay, we have another question from online that said, we want to take some QCDR measures and submit into MIPS. Should we have them NQF endorsed first? And I've heard this question several times, and the usual answer from CMS is, no, it does not have to be endorsed, but it always helps. Does that still sound accurate?
Yes, that's accurate, Vince.
Yeah.
You know, like we said, you know, endorsement prior to coming on the MUC list is definitely preferred. However, we recognize that you know, can have time limitations and you know, just be difficult to do it before it gets on the MUC list. So, like Maria and I have both said, you know, we ask and we recommend that it be quote-unquote endorsement ready, where, you know, you feel like you could fill out, you know, all of the questions and, you know, fill out all the information for endorsement, but maybe you know, just submitted your intent to submit form and it hasn't, you know, actually gone through the process yet. So hopefully that answers that question. And that's across for all of the programs, not just QCDR, not just taking a QCDR and creating and submitting it for MIPS quality. That's for all of the measures.
We did have another question of someone, how do we register for the other April webinars? There is a link at the end of this slide deck today that will be to the MMS support email, and when you send to that, we will send you a link to register for all 3 of the remaining April webinars, and we will also add you to a mailing list for future pre-rulemaking or measures under consideration communication.
Sorry, just to jump in there, Vince, as well, I think, Martin, if you could also, you know, maybe once or twice through the presentation, you know, send out one of the chat boxes. I don't know if people are going to be able to click, you know, I don't know if they're clickable in the webinar piece, but if you can copy and paste the links in the chat function, Martin, people can try and register that way, and that way they don't have to email.
That's great. That's new technology. Thank you. I think these 2 are for Susan. One said, is MIPS peer review only necessary for MIPS, not for hospital-based measures?
Yes, that is correct, for MIPS quality measures only, not for the hospitals.
And then the second one, Susan, if you would, it said, must the peer-reviewed manuscript already have been published, or what if it's just submitted? And what if it's been accepted for publication but is not yet published? Is that okay?
Okay. The peer-reviewed the form that you're filling out for us, it's actually a requirement that CMS has statutorily to fulfill, and we have to fulfill it on an annual basis. So we use your form along with the other material that you submit in Jira to not only evaluate for MUC list suitability, but also because anything that does proceed to the MUC list, we have to we use your form to put it in our template for our peer-reviewed journal article, which we must submit and at least have it considered for publication by no later than November 1st of a given calendar year, because it totally links in with the statute for MACRA and also the legislative cycle requirements for the physician fee schedule and when that gets published. So you yourself for your measure in a peer-reviewed journal article, no. You don't have to have your measure published in a peer review. It's great if you do. It's wonderful if you do. But this is for our requirement, which is based on a statute.
So they just have to fill out the...
Just fill out the form, yep.
Just have to fill out the form.
Yep.
You don't have to actually put your measure in a peer-reviewed journal article. You just have to fill out the form.
Right. And our requirement is that the article has to be submitted and reviewed, not that it necessarily gets published. So just to let you know.
Okay, thank you. Our next question is relating to the needs and priorities session, which will be a week from Thursday, on Thursday, April 25th. And the caller asks, will we be discussing specific needs and priorities for outpatient and ambulatory surgical programs? Will it review all 18 programs? The answer is yes. It will review all of those programs. Each program goes in turn following an outline, and that's what the 2-hour needs and priorities session is intended to cover. So each program will have a chance to describe what its particular needs and priorities are for the future. Kim or Maria may have more they want to add on that.
Nope, that summarizes it. I guess the only thing I would add is that shortly thereafter, there's a corresponding document that will be published as well.
Hi, this is Martin. Everyone has been unmuted right now, so please feel free to speak up and ask a question if you're interested.
Hi. This is a question about the ECQM. So it's discussion about providing the N and number of patients and practices or practice sites or clinicians, et cetera. Is there any requirement that the measure be tested in more than one EHR system, or is that negotiable?
Christine, if you could take that question.
Sure. So CMS typically looks for at least 2 different test sites with 2 different EHRs to help feed into the understanding of feasibility, as well as they're considering it for a national program. So usually at least 2 sites worth of data in EHRs.
Thank you.
All right. This is Mary Sheehan. I am going to go ahead and go over an overview of the CMS Measures Inventory tool. I work at Battelle and one of the contractors that supports CMS in their work for compiling all of the measure information. So if you can go to the next slide, please. So for those of you who have been a part of these MUC webinars before, we did a demo of this last year, but for those that are new or who may not have heard of the CMS Measures Inventory tool before, it's an interactive web-based application that we've worked on over the past year and a half to really try and be a user-friendly way to be able to search and find measure information. We do span the scope of measures under development through measures under consideration, and then those measures that are actively used in CMS programs or initiatives, and then even those that have been removed from programs, we do try to retain that historical information for those of you that are still doing development. You get a chance to see what has been used in the past. We try to offer information that links to different resources that may be able to then say, why a measure might have been removed for that program. Maybe it was topped out or something like that. But we want to make sure that there's access to information across the scope. We currently have about 37 programs and initiatives in CMIT that covers 2,238 measures, so we do have quite an array of measures that are in there. The measure information is inclusive of things like the title, description, numerator, denominator. We work with NQF to make sure that we have the most up-to-date NQF identifiers and endorsement status. We try to stay up to date with what they're doing in terms of identifiers for ECQMs. We've worked very closely with CMS over the past year to make sure that we've been inclusive of their meaningful measure area framework so that you can find measures that are related to those areas in particular. We also provide information on the type of measure, the data source, and then the status of that measure within a given program. So we do work to update that information 3 times a year. We do that to correspond with the federal rulemaking process. So as proposed rules are coming out for various programs, we scan that information and we collect that data, and then we send all that information that we found off to CMS program leads to validate that, and then we publish it. And then a corresponding final rule will come out for that program, and we do the same process. So again, 3 times a year, we update that, and then we do include, after the MUC list has been published each year, we incorporate that into the final update for the year. Typically, for that measure information that's collected through the end of November, early December, so those rules that are released then, and then the MUC list, all of that information is ultimately updated in February. That gives us enough time to do that data collection and then have CMS validate that information. We really hope that the CMIT tool can be useful for you as you start to prepare your submissions to Jira. So oftentimes the requirements for submission will ask questions like, is this measure used in another program? Has this measure been submitted to the MUC list before? And if so, what's the identifier? Are there similar or competing measures within a program? So I do want to make sure today we'll do a brief demo that I can show you how to find that information and how you can search in CMIT quickly to be able to get that information for your submission. One of our new functionalities and one of the things that I hope that you'll be very excited about is our addition of what's called the Environmental Scan Support Tool. This information and this functionality is going to be released into CMIT in the next couple of weeks. And so you'll be able to use this information. We've been working to automate an environmental scan search process that will help you prioritize and find some of this biomedical literature. We've done this for any measure that's a process and outcome measure that's in CMIT. And so we hope that as you're looking for information about these various measures, that this tool can help you quickly identify the most relevant information for those measures. You might be wondering how this works, and I will say that we've basically taken the clinical quality measures and created an ontology that basically it describes the concept of a measure. We've looked at, identifying the population or the health status or the processes that are a part of what that measure concept is, what the expected change or what the goal change is as a result of that measure. And then we've worked to build that ontology to then have an artificial intelligence tool basically scan and be doing searches to identify the most relevant PubMed content. And then also we've done some manual extraction based on some of the sources that are identified in MIPS forms. And so we've been really working to try and build a comprehensive library. It's updated once a month, and so the measure information regarding those literature findings that come back for the measures should be up to date at least every month. And so we do try to make sure that we have the most timely information. And so, Martin, if it's okay, I'm going to share my screen with the group and do a quick walkthrough of CMIT here, and then do a quick wireframe share of what the environmental scan tool might look like. So I am going to share my screen. This is the landing page for CMIT, and again, the web address for this is just cmit.cms.gov. And then this is the repository of all of the measures. And so this is where we're hoping that you'll be able to easily see if this is a measure that you're interested in submitting for MUC, that you'll be able to see that it's used in a variety of different programs here. And so you can search for keywords if you were interested in searching for measures related to diabetes. You could come here and you could find your diabetes measures. To get to the actual specification information, you click on the measure and you come to the tab where you'll see the various high-level specifications in terms of description, numerator, things like that. You can get more information related to who the steward is or maybe who the developer was. There's characteristics here in terms of the measure type, if there's NQF information related to this. And then you can also get into program-specific information. So again, the status of each measure within that program. And then you can then click on to find more information about the data sources used for that, what the date of implementation was for that. So getting to, again, some of the information that will be helpful for your Jira search. These are all data points that are filterable. So if you're interested in seeing what the considered measures were, if you need to find ones that have been submitted before, you can click on this current status and click on considered measures. And again, I did a search on diabetes, so these would all be various considered measures that have been submitted before, and you can find them there. And if you wanted to do a comparison, you could do, you can click on add here, and you can do, foot exam, eye exam, and then, various things. And you can come up, you can select up to 3, and you can click on measure comparison. And then this will actually show you where there's differences in the measure information. And so you'll see here anything that's in yellow is a mismatch, and then anything that aligns will be here across the in white. So I'll take you back to the main page then, and then you can always you can clear those out by clicking on Clear All here. And then you can come back to the measure inventory page. And again, if you go to a considered measure, then what you'll see is that you can come to a measure, and then at a program level, you can come down and see what that MUC ID was or what the MUC year was for that measure. And so again, we're hoping that you'll be able to easily find that information for your submissions. And I want to take a second and show you the wireframes that are of what it will look like to be able to search for measures. So again, if you click on a measure, you'll see that they have these tabs here. And so what you'll learn when we release this at the end of the month, the environmental scan tool will come out, that there will be a new tab that's added here for environmental scan. And if you were to click on that, it will show you a page that looks like this. And so you'll see that for this measure, these are the return searches for articles that are relevant. So you'll see the relevancy score here shown by a bar of how relevant this article is to the topic. And so you can get that information here. And then if you click on the associated measure, so this view list, you'll get a pop-up box that will show other measures that this document is relevant for. So you can see what information is available, or what measures are tied to that article. From there, if you were interested in seeing what the full text article is, we do have links. You can click on the full text button that will link you directly to that article if it's of interest to you. And then you can also do an export of all of those citations. So, you can export it into an Excel file or into an IRS file and be able to have all of that information specific to those, to the measures and the articles relevant to those. And I think I will turn it over to Helen Dollar-Maples, who is going to speak on the MAP process.
Thank you, Mary. Thank you so much for that overview of CMET. We really appreciate you taking the time to show it off. And again, my name is Helen Dollar-Maples. I work alongside with Kim Rawlings, and as she mentioned at the top of this presentation, we are your MUC POCs, so always feel free to reach out to one or both of us. I have the distinct pleasure of presenting to you the MAP work, and currently we do have this contracted with the National Quality Forum, and the MAP is the Measure Applications Partnership. So the role of the MAP, and we're going to kind of talk about this in another slide as well, but it's really just the basics of it, is really that the MAP comes together and takes a look at all the measures that were on the MUC list or the measures under consideration list, and they take a look at it and they look at the program in which it's being considered for and make the determination on whether or not they think it actually fulfills the needs for that particular program. They look at it, they determine if it seems to fill a gap. Is it actually fully tested and ready to go? Without really looking into the scientific rigor of the measure. That's for another process. And then at the end of the day, they provide a recommendation back to the HHS secretary and whether they believe that this measure is ready for prime time and for use in one of our CMS Measures program. So what is the value of this input? Well, the MAP is made up of a multi-stakeholder group. So it crosses a variety of different perspectives and brings them together so that they can have this dialogue to, again, discuss whether or not they believe that the measures that we're considering for programs, that it's going to fulfill the needs of that program. So, and it also allows for a very transparent process so that we are not just making these decisions in a vacuum over here at CMS, that we do value the input from the multi-stakeholder groups, as well as when we put the list out for public commenting, we actually value that comment period as well, and hearing what our stakeholders that may not be intimately a part of the MAP, but what they think of these different measures as well. So this is what the MAP structure looks like. We do have a coordinating committee, and they kind of basically adjudicate the recommendations from the various MAP work groups. We have the hospital work group, the clinician work group, and the post-acute care work group. We have just recently added a rural health work group, which those folks will actually be tasked to review every measure on the MUC list and how they believe that it could fulfill a need for the rural population and for those particular patients and beneficiaries that we have. So the various types of members. The MAP members include organizational representatives, you have subject matter experts, and you have federal government liaisons, or LNOs. So by bringing this group of folks together to discuss and deliberate on these measures really, again, lends to an open, transparent process and allows a variety of voices to be heard regarding each measure on the MUC list. So the MAP measure selection criteria. What they're looking for are measures that are endorsed or endorsement ready. Again, though, as already noted earlier, these measures don't have to be endorsed. But as long as they're endorsement ready, we would really appreciate that. Just makes it easier to know that they are prime time, ready to go. We also want to ensure that measures adequately address the CMS healthcare priorities that Kim spoke about during the measures portion of her discussion. That these measures are actually filling gaps within each of our programs. There's also an appropriate mix of measure types. Outcomes, we really are looking for outcome measures, but sometimes if we understand that a process measure needs to get us to that point where outcome measure is developed and ready for use. We would like to see more person and family-centered care and service measures. We want to definitely promote alignment across our programs and within the program itself. And absolutely, we look at the burden of a measure and how that might impact our providers and those who are reporting on our measures. So, as already noted, the MAP work groups, each of those must decide if they believe that a measure is ready for use in a CMS program, what the recommendation might be. They look at each and every measure on the MUC list and make that determination. And they also, if you look it up on our website, you'll see last year's MUC list, and you'll see that there's a rationale for why the work group decided on that particular decision category. Speaking of decision categories, here they are. So we have at the top support for rulemaking, which just means that's an excellent measure. The MAP is in favor of it being ready for use in one of our programs. Then you have the conditional support for rulemaking. They believe that it is pretty much there, but maybe just needs a tweak or two, or maybe they're looking for it to be endorsed and to ensure that it is scientifically rigorous enough to actually be used in our programs. Then you have the do not support for rulemaking with potential for mitigation. Again, that might be that they believe that the measure in of itself is a good measure, but that there is some much needed work to get it to where it is ready for prime time. And then there is just do not support for rulemaking at all. They just think that it's just not the right measure for that particular program. So NQF staff, they will conduct a preliminary analysis of each measure on the MUC list Once that MUC list is published, the NQF staff will take a look. They have an algorithm in which that they use to come up with their preliminary recommendation or their what they believe is the direction in which the MAP may consider. So they will provide their preliminary analysis to the MAP group, and then they kind of take it from there. And this is just the algorithm, just to ensure that the measure, is it an outcome measure? Is it addressing gaps? Is it addressing any kind of quality challenges? Can it be feasibly reported? If it's actually in current use and that no issues have been identified. So here's the MAP approach to pre-rulemaking. And this is just a basic timeline. As Kim already stated, we are looking to adjust this slightly, but it shouldn't really be a huge impact on the MAP work. So as you can see, in September, the coordinating committee will discuss strategic guidance for the work groups to use during their pre-rulemaking. In October and November, we're going to have these web meetings with the work group members to ensure that they understand the process and their roles within the pre-rulemaking cycle. And then on or before December 1st, the statute dictates that the MUC list will be published. And then between November and December, NQF will put out the MUC list for public commenting. And then right when the in-person work group meetings start, they will turn off the public commenting tool. And the work groups will come together and they will discuss each measure on the MUC list. Then in between December and January, January being when they have the coordinating committee meeting, they'll have another public commenting period so that folks can comment on what they believe or what the MAP work groups came to consensus regarding each measure. And then the coordinating committee just kind of adjudicates the MAP work group's recommendations. And then on February 1st, no later than, NQF will deliver to CMS the list of measures and their final recommendations. So we just closed out the nominations for folks to be able to serve on the MAP, and this is just in case anybody's ever interested in being able to serve. 1/3 of the seats on MAP are eligible for reappointment each year. And as you can see, the formal call for nominations occurs early spring, but they accept it pretty much year-round. Here is the link that if you're interested in serving on a MAP, you may click on that and submit your name or nominate a colleague. And we do, again, we are always looking for a voice in a variety of different perspectives. All right. Well, thank you so much. I'm going to turn this back over to my colleague, Vince Brown at Battelle, and he'll talk to you and walk you through a little bit of Jira.
Thank you, Helen, for that introduction. My name is Vince Brown. I work for Battelle. We are the Measures Management System contractor for CMS. And I appreciate the opportunity to go through an overview of Jira for 2019. What we have are a few slides just describing the differences. For the benefit of those who have submitted measures in past years, we like to highlight what has changed. Mostly this year, things will look the same from 2018. I do want to direct everyone to the pre-rulemaking website where there is a downloadable user guide that walks you through all the questions and screens and all the screen guidance so you can familiarize yourself with that before you jump into Jira. Also, today's brief overview is directed more toward those who are familiar with Jira. The open forums, which will be this Thursday and next Tuesday, those will be more for people who are new to Jira and might just want to walk through, or it's more interactive in Q&A. So anyway, what's new for 2019? We did rename one program. I'll detail that here in a moment. Several of our drop-down menus have different choices this year. We asked the programs you know, should we change this label? Nomenclature is always evolving, and so we update some of our drop-downs. To me, the most important change for 2019 is in the area of your healthcare priority that Kim covered at the top of this hour, and the meaningful measure area. In 2018, users were required to select one and only one priority and one and only one meaningful measure. For 2019, at your option, this is not a required field, but at your option you can add a secondary priority and a secondary meaningful measure. What some feedback we got was that people had, it was sometimes hard to decide which priority fit this given measure best. So you'll be able to put that in there if you want to, the secondary. I should say the primary remains required as it was last year. You must select at least one priority and one meaningful measure for that candidate measure. But the secondary, again, is at your option. You have a few different choices for your data sources question and how the measure will be reported to CMS. And then we added to the screen guidance for instances where your measure, the terms in the drop-down just don't fit what your measure has. So we added to the screen guidance to encourage users to use the comments at the bottom of the data entry screen to elaborate or define specific sources that are not in our drop-down list. So the one program that Maria alluded to earlier is that the program formerly known as EHR Incentive, this is for eligible hospitals and critical access hospitals, that's been editorially renamed to be called Promoting Interoperability. So that program name will look slightly different this year. One other editorial change, we would get frequent questions, so what's the difference between an exclusion and an exception? So we just added the word so that that one field encompasses both of those ideas. You can put your exceptions or exclusions in there. Here's another change. There was a meaningful measure area last year called patient-reported functional outcomes. That meaningful measure area has been simplified to be functional outcomes only. So again, if you're comparing year to year, that one meaningful measure area will look a little bit different. And again, as I said, the secondary priorities are optional for the healthcare priority and the meaningful measure area. I wanted to point out also one change that's not on the slide. For your NQF ID number, if the measure is in the National Quality Forum system, that identifying number had previously been a numeric value up to 4 digits. At some point, NQF added the idea of a letter at the end to designate some measures. So we've expanded that field. So if it has some of the measures will have an E at the end that has special significance in the NQF world. So we've updated Jira to allow that. I would also point out for the MIPS, Merit-Based Incentive Payment System program, as it was last year, when you enter a measure for MIPS, you will need to decide whether it is a cost measure or a quality measure. This is still all one program, MIPS, but we do need to distinguish between those two when they come into Jira. And I think the people that are doing cost measures know who they are, and that's a pretty well-defined set. And what historically has been MIPS is now called MIPS quality. So you'll still have that choice just as you did last year. So here in a moment, I will switch screens and do a screen demonstration of Jira. I want to walk through the new fields and talk to some of the changes in requirements. We'll discuss also how to add new users to gain access to it and the template and a few of the other features of using Jira. So I just put this splash screen up here. You need to have an account with Office of National Coordinator for Health IT, ONC. You need to have a Jira account with them to begin with, and then the user guide describes how to gain access for the measures under consideration list for each year. So it is a controlled access environment. I'm going to just click login here. And it may log you into a different year's project if you've used it in past years. So you want to make sure you come up here to where it says projects and click that and go to the 2019. Select that project. You'll see we have no issues yet. We're excited and looking forward to receiving new measures this year. The system will be open until June 3rd. And so it's open today and anyone can start adding measures at any time. So once you're in the 2019 project, you would go to that yellow button at the top that says Create. And I would say be sure to check, and again, make sure you're in the 2019 project. Make sure that this issue type says Measure Submissions. Some users, when they first get in here, it will default to a different issue type. So if you make sure it says Measure Submission, that's where you want to start to, again, add a new measure. It's basically a screen that you scroll through, and I will point out, you may or may not be able to see it on your screen, but there are red asterisks besides the required fields. So if you see the red asterisk, you have to complete that field or it won't let you create the measure record. I'll just point out where the new program is. This is the one that was last year, EHR Incentives, and now is named Promoting Interoperability. And then again, just to point out, there's MIPS quality and MIPS cost. So you would select one of those two if you have a MIPS measure. And as always, you can enter as many programs as are appropriate for your measure. Not much change really. If you used it in prior years, you will not see much change this year. Here is the field that's called Exclusions and Exceptions now. So that's a little clearer. I want to scroll down to the healthcare priority. So you'll see this field is now called What One Primary Healthcare Priority Applies, and it has an asterisk. Notice that the primary meaningful measure doesn't have any drop-downs. That's because you haven't selected a priority. The system is context sensitive, so once you choose a priority, then your meaningful measure drop-down populates with the appropriate meaningful measure areas that are subsidiary to that priority. So that's how that would work. Then the new fields this year are what secondary priority applies and what secondary meaningful measure. And again, you're asked to add these to your measure only if applicable. So the secondary ones are optional for you. Here's your peer-reviewed evidence that has come up on the call. Here's NQF status and NQF ID. Again, everything else from here on out looks pretty much as it did last year. I want to draw your attention here at the bottom to the comments field. Scrolling ahead here. So this is the box for you to add comments. So anything that was not covered, or if you want information in your measure that was not included in the drop-down or otherwise you were not able to say it, this is the place to add it. And of course, when you add a comment, you should describe what field you're talking about and then add your information right here. It's an open-ended text field. Susan Arday earlier presented about the MIPS peer-reviewed journal article attachment. That is a separate Word file that you can get at through the links described in her slide. And then once you have completed that, this is where you would drag it, or you can browse to attach the peer-reviewed journal article attachment to your candidate measure record. That again is for MIPS only. Other measure types, ECQMs, and other measure types have required attachments, so this is where you can attach anything. I think there is a limit of 10 megabytes. If you need to exceed 10 megabytes, please contact us or submit a question and we'll figure out some other means of getting the information all together. But that limit has been successful in the past. For an example, the screen guidance here says if it's an ECQM, you must attach Bonnie test cases and attestation about the Value Set Authority Center and the NQF feasibility scorecard. So like I said, depending on the type of measure you have, if you follow the screen guidance, it will tell you what kinds of attachments are required for that. When you are finished, you'll click Create. I'll do that. It's going to give me a bunch of errors, but this is the button you create. It's telling me that in red here that I didn't fill out all these required fields, but I just wanted to demonstrate for you the Create button. An important feature of Jira that we've asked about and we've not had any luck to resolve it is that each measure must be entered in one session. Jira does not support the idea of saving your work and exiting and coming back later and completing it like some tax preparation online software would do or others. Jira was not designed to do that and doesn't support that function. So users are surprised by this every year, so we try to communicate it clearly that there is an offline template on the Pre-Rulemaking website. It's a Word file that you're welcome to use to gather your information in one place so that when you get into Jira, you're all ready to drop all the measure data into that Jira interface in one fell swoop. We've had people looking at the timestamps who are able to put a measure in about 6 or 8 minutes. If all their information is together online, it's a matter of copy, paste, go. That template has been very well received, and a lot of users have found it helpful to make sure that they have everything together. There are other functions in Jira to ask questions, to provide feedback for improvements, or to, once you have entered a measure, then you cannot go back in and change that record, but what we have a mechanism separate called a change request or a modify candidate measure. So that's the method that you would use to request a change, because we know things change, but with multiple reviews happening at various layers of CMS, we need to standardize that. And so that's what the change request issue type is. That allows you to request to make a change. Again, we'll go into this demonstration and have more question and answer on our open forum sessions on Thursday, the 18th, and Tuesday, the 23rd. That concludes the demonstration part. So I think we're ready for questions. We got 2 questions while the earlier talks were going on. One question, and Helen or someone may be able to answer it, how long does it usually take to get an NQF endorsement?
Hi, yeah, so this is Helen. So it depends on where you consider the start of the endorsement process. Because the first step is submitting an intent to submit, and those are usually, or those are due either January for the spring cycle or August for the fall cycle. But the actual measure submission for spring is usually in April, and then for the fall, it's usually like November. But but if you take it from the actual measure submission deadline, it's usually about a 9-month process for the review by the standing committees, and then for it to be adjudicated by the CSEC, and then to be considered endorsed.
Okay. And we had one question come in for Mary Sheehan, which was, if someone were to discover a potential error in the CMIT database, how would he or she report that?
Yeah, thanks, Vince. So if you notice anything that you want to have a question about or you'd like to see updated, if you submit it to the MMS support at battelle.org email address, just let us know what measure that was, and we can look into it and either get you a response for why it's shown the way it is, or we can go ahead and make that update. But yeah, we welcome feedback in terms of any updates that need to be made, or you know, any new sets of measures or things like that. So we're happy to take that feedback at mmssupport@battelle.org.
And Mary, this is Maria Durham. I believe you do releases 3 times a year, so sometimes it could literally be a matter of timing and, you know, kind of queuing it up for the next release. And
Yeah, thanks, Maria, and that's a good point. The next update is actually for scheduled at the end of June, so we are preparing now to get the proposed rules that will come out this month with the hospital program. So yeah, thanks for that. That's a good point. It's some of it is just a matter of catching it in the next update.
Okay. Here's a question that Helen, I think, had alluded to, or Kim. It said, is the submission process different for a measure that had been submitted before but was not selected? And I think this is referring to the MUC list, so it may be Kim's part of the presentation. And if I could, I think the process is the same. The measure needs to go through the Jira measures under consideration submission. Presumably then this measure was put into Jira before and CMS looked at it, but no programs accepted it for the MUC list. I do see this as a frequent question. People say, should I just send the same measure through again? Well, if circumstances have changed and it's more likely to be accepted this year, then yes. Presumably the measure, whatever caused it to be not accepted, would be different, you hope anyway. Maybe you have more testing data, or maybe some of the specifications have changed. But in general, the process is you would just submit it for the current year's MUC list, and then CMS would again review it. Now, there are questions in Jira that say, was this submitted before, for which programs, so you want to put that history in there just so that CMS and anyone else looking at that measure is aware of that measure's history and you know what's different about it this time. So there are places to put that kind of information in Jira that may help your measure to get through. And Kim, I don't know if you want to add anything on that.
Yeah, so this is Maria. That's super thorough. You know, I would just say that, you know, because I'm trying to be respectful of everyone's time. You know, if a measure isn't, I think Vince really laid out everything, but if a measure, you know, isn't selected for the MUC list, then it does need to be resubmitted. But I would also kind of caution you to look at why it wasn't accepted. Because if it's, for example, you know, not accepted because it's not fully developed and tested and it subsequently is, you know, that is a good reason to consider resubmitting it. Or if there's a new gap area that wasn't a gap area before, that would be a great reason to resubmit it. But if someone, if a program did not put it on the MUC list because, you know, it was, you know, a process measure that was more of a checkbox measure and they were looking for an outcome measure, you know, you know, unless the measure has significantly changed, I think there's, you know, a probability that it would continue to not be considered. So, you know, I would definitely circle back and look at why it wasn't accepted.
Just want to go ahead and thank everyone for joining us at our pre-rulemaking kickoff meeting. As said, Helen Dollar-Maples and myself, Kim Rawlings, are both the MUC coordinators for 2019. And on the Battelle side is Vince Brown. Please feel free to reach out if you have questions. And we do have the webinars Thursday from 1 to 2, Tuesday from 1 to 2 for the Open Door Forum to review in-depth Jira, and then next Thursday, the needs and priorities. And Martin has put in all of the registration links, so they are at your fingertips. Please feel free to register and join us at our future webinars. Thank you, everyone, and have a great rest of your day. We look forward to seeing your measures.